Hello?
Yeah.
Yeah, Umeshan, Placid, we can see you. Go ahead and show your case,
Hi,
record your
hi.
case. What?
Hi, Srinivas.
Good evening.
Good evening.
Yeah.
Greetings from Aster Kannur. I am Dr. Placid Sebastian. And I have Dr. Umeshan, my colleague. Unfortunately, we couldn't do the live case because of patient is not doing well due to non-cardiac cause. The case has to be deferred. So we will share one of the cases which an interesting case we have done recently. So over to the case.
Thank you, Srinivas, for us to do this presentation, and sincere apologies for not going on live. Our patient is a 66-year-old male. He's a diabetic hypertensive. He's already on treatment for coronary artery disease. He had undergone PCI to RCA and OM in 2017. Now he presented with effort angina and his TMT was positive. And echo showed no RWMA and normal LV systolic function. He has got mild aortic stenosis and mild aortic regurgitation, and there was no evidence of PH. So he was taken up for a diagnostic coronary angiography. This is the caudal view. I don't know how you can appreciate there that the distal left main looks hazy, and there is some the left circumflex of ostium is also not looking great in this view. This is again the left circumflex, the distal left main looks diseased, and circumflex of ostium is also looking diseased in this caudal view. Can you go to the next view? Yeah, here you can definitely appreciate that the distal left main is significantly diseased, and the stents which were placed in the OM is functioning well, and the circumflex flow is good. So I'm sure that you can appreciate the distal left main disease there. This is the right coronary angiogram, and here again the stent is patent and the RC is flowing well. So we have this patient has got a distal left main disease, and the circumflex ostium was, in some of the views it looks like the circumflex ostium is also involved, and his previous stents were patent. So our plan was to do an image-based left main coronary artery intervention. Angiographically, our concern is whether the circumflex ostium is involved or not. So whether we should go for a provisional stenting strategy, or we should go straight away from the two-stent strategy. Anyway, the imaging will give an idea about it. Over to Placid for our plans.
Yeah. Yeah, thank you, Umeshan. So the difficulty we had was the angiography. We are not very sure about the circumflex ostium and the ostium of the LAD, whether to address that, whether to go for a professional stenting from left main to LAD and then see how the circumflex, or do a image-guided angioplasty. So what we did was we first did a pre-procedure OCT run from LAD into the left main. Yeah.
By the way, in between, any suggestions regarding the imaging modality, whether one should go for what is the imaging modality, IVUS versus OCT in this type of situations?
Yeah, Umeshan's a very interesting case. There is a distal lesion in the distal left
Hi,
main.
Salomoni. Hi, Salomoni.
Yeah. Hi, good evening, sir. Very significant lesion in the distal left main. And on angiographically, we feel that the ostium of the circ and the LAD is not diseased. That is what I could interpret. But any modality of imaging, IVUS or OCT, will give an idea whether the LAD ostium and the circumflex ostium is diseased or not. And I think we are seeing a OCT, that's a good thing. This is a run from the LAD, isn't it? Left main to LAD.
That's
yeah,
right.
it's
yeah, you can run the
LAD
OCT
to the
yeah.
left main. Placid
Please
will
keep running the
sure.
OCT.
Placid will, yeah.
Yeah,
okay,
please run the OCT, and we could find that the distal LAD is quite, luminal area is around 8.3, though the diameter is coming around 3.4. And it's near entering the ostium, there is a significant narrowing of the ostium of the LAD, as well as you can see that significant narrowing with some amount of calcium and fibroplastic plaque. And at the level of the circumflex ostium, there is a significant narrowing of the ostium of the LAD. And the distal part of the left main also showing significant luminal narrowing. It's around 4.5 luminal area. So the mid and the proximal part of the left main is relatively disease-free. Yeah, with that we have confirmed that the ostium of the LAD is also significantly diseased.
Now, can you just show the LAD diagonal, LAD circumflex bifurcation? Go to the point, rotate the OCT if you can show that. Yeah, this is the left main. I think you should still go distally. Yeah, come back slightly. This is the tight lesion.
Come back.
Yeah. Go a little bit down.
Yeah. Come back to the
circumflex ostium.
This is the circumflex ostium. Okay.
Yeah.
Yeah, okay.
So here also we are not very sure about the ostium of the circumflex. So we thought we'll go for the next OCT run from circumflex into the left main to define the ostium of the circumflex. So this is the OCT run from circumflex to left main. So here you can see that there is some significant plaque. Just pull back so that run. Yeah. So some amount of disease. But overall luminal area is relatively good. But when it comes to the ostium, you can see that significant luminal narrowing of the ostium of the circumflex as well.
What was the luminal area there in the ostium of the circumflex? Because the display is not getting shown here. The MLA, that areas we are not able to see here.
Yeah, luminal area is coming around 3.3. Yeah.
So Auster L63.
Luminal area is almost like 3.
Then go ahead, please.
Yeah, we thought it is important.
Yeah,
And
yeah, you can proceed a little faster. You can go ahead. What you have shown, continue to show.
yeah.
Okay. Right. So with that, we thought two-stent strategy is the better choice, and we decided to go for a decay crush because that is studies have shown decay crush is the best treatment of option. So we wired both the LAD and circumflex with the floppy wire, and pre-dilated the circumflex ostium with a 2.5 12 NC balloon. We went up to 14 atmosphere. Then we dilate the LAD with a 3 into 12 atmosphere, 3 into 12 NC balloon with 14 atmosphere. So that was the pre-dilatation, and the pre-dilatation angiogrowing showing significant plaques in the distal circumflex and the ostium of the circumflex. And first we placed the stent into the circumflex into the left main. That's 3.5 into 12 Zions expedition stent. We deployed it at 10 atmosphere. We placed a balloon before that in the left main to LAD, and we crushed the circumflex stent with 3.5 into 12 millimeter NC balloon. We went up to 18 to 20 atmosphere. So that was a crush, and then after that we rewired the circumflex. Rewired the circumflex. We made sure that the wires passed in the proximal strut. We didn't do an OCT here. We went by a stent boost, and the circumflex stent was dilated serially, initially with a smaller diameter balloon, and then we dilated with a 3.5 into 8 millimeter NC balloon. We went up to 18 atmosphere. So after that, we did the first kiss, that is the 3.5 8 millimeter in the circumflex and 3.5 into 12 in the left main to LAD. So this was the first kiss we have done. And after that, we have placed the stent, that is the Science Expedition 18 into 3.5 into 18 from left main into the proximal part of the LAD. Yeah, we made sure that we are not covering the ostium of the left main because the ostium of left main was disease free. So that was deployed at 14 atmosphere. That was the Science Expedition 3.5 into 18. So after stenting the left main to LAD, still the blood flow is good, the carina is looking good. So, yeah. So we have recrossed and we first did we did the post dilatation of the LAD stent with a 3.5 into 8 millimeter balloon. We went up to 20 atmosphere. So entire length we dilated. And this is the second kiss. This we did both LAD and circumflex 3.5 8 balloon. We went up to 14 atmosphere optimum pressure. And after that we did the final part, that is 4 into 8 millimeter NC balloon.
The angiographically looks.
So this is the final angiographic result after the final part. So any comments?
Angiographically, it looks great.
Or any different strategy?
Angiographically, it looks excellent. Did you do OCT again or not? Anyway.
Yeah, we did an OCT again.
Yeah,
This is the
please go ahead and show that.
Yeah, please do show the, yeah. So this is the post angioplasty OCT run. We did from LAD into the left main. Distal part of the stent is little malapose, which we post dilated later. So this is the OCT run. Yeah, so you can see the ostium of the circumflex. It's wide open. Yeah, please show the run. Yeah. Coming back to the little bit of artifact coming in this. Yeah, and left main we are getting a luminal area nearly 14 to 15. Yeah, this is the left main stent, well opposed. Yeah.
I think you should go to the bifurcation point.
We have not done. Yeah.
You go to that LAD circumflex bifurcation and go there, go still down.
LAD circumflex bifurcation point.
Still down.
LAD circumflex bifurcation point.
15?
Yeah.
Oh, yeah.
Yes. So you can see some struts across the circumflex there. And
Yeah.
Yeah.
Yeah, they're broken
the
struts.
3D navigation mode is not getting transmitted properly here.
Yeah, unfortunately, there were a lot of artifacts. The 3D navigation was not coming properly there.
Anyway, the struts appear to be broken by the DKU, second Krish, what they have done, I think.
Yeah, there are some struts across the circumflex
Yes,
there.
yes, there are.
There are. So the problem might be like when you are crossing, whenever we are doing a DK crush, and if you have an imaging, at least you should do at least 3 or 4 times OCT. Basically, why they suggest is, when you cross it in an ideal cell, your final outcome will be better than this. Whatever the struts we are getting across the side branch is basically if we have crossed it in a non-ideal cell, probably something very distal or in a very but that is the endmost strut or something like that. you try to, we tend to get such type of connecting carina struts across the side branch. And one more thing is, when you just put the first circumflex stent before crushing itself, it is better you do a good pot and then you crush the circumflex stents. So these are some of the points which we have observed might help you to get a better results and better bifurcation point there.
Thank you. Points well taken. You're finally,
So do you
can you show the
recommend,
final picture?
yeah,
What did you do after this?
Final angiogram?
Post-dilated again with a bigger balloon, you said. And the final picture? Yeah.
yeah, this is the final picture.
Yeah, this looks good.
The result looks good, and I think patient did well on follow-up. Thanks for showing an interesting decay crush bifurcation case in spite of patient having not being there, and you did your best in the existing scenario. Thank you, Umesh. I'd like to mention Umesh and we did
thank you, Dr. Srinivas.
DM together in HCPGI, and we have fond remembrances.
Thank you
Placid. Thank you, Umesh.
I mean, we're extremely sorry for not
No problem,
not
no
able to
problem, it
see the
happens.
live case.
It's okay, no problem at all. Can we, if there's no further
Thank you,
thing,
Dr.
we'll
Srinivas.
move
Thank
to
you, Dr.
Girish.
Selvamani.
No issue.
Your points are well taken.
Right, thank you.